Indirect ophthalmoscopy, or IDO, provides a panoramic stereoscopic view of the retina, not attained by any other single instrument. We owe it to our patients to do a complete retinal examination. Despite these compelling attributes, indirect ophthalmoscopy seems to be somewhat falling into disfavor among residents. This video aims to reverse this trend. Before getting started, let's look at the optics that are based on Gullstrand's principle of both the examiner's viewing beams and the illumination beam being imaged in the patient's dilated pupil. Light rays from the patient's retina enters the observer's pupil through a set of prisms and mirrors in the IDO. The headband has two knobs. The back knob is for circumferential tightening, for the indirect to rest firmly and comfortably on the head without movements on head tilt. The top knob adjusts the vertical height of the device to rest above the ear. The oculars should be closest to the eyes to obtain the maximum field of view. A lever to adjust the vertical height of the housing is also available. The IPD can be adjusted by moving the eyepieces and adjusted one eye at a time using the thumb as a guide to center the beam. Vertical light beam position can be adjusted by rotating a knob. The light beam should be in the top half of the field of view for maximum stereopsis. Illumination intensity can be adjusted using an on-off switch cum rheostat. Dangling wires are not only a safety hazard but also a distracting nuisance. Cordless devices are a great substitute and afford unrestricted mobility. A 20 diopter condensing lens is commonly used and provides a 40-degree field of view and a 3x magnification. The white trim should be towards the patient. Model eyes or improvised ones table tennis ball may be used. The lens is full with the image at 2 to 4 inches from the object, and one should learn to hold this image. Now, wear the indirect and start viewing the retinal details on the model eye, remembering the rigid rod or optical bench principle. The patient's pupil, the center of the lens, and the center of the scope should all be aligned for clear view, else the image is lost. The examination table should be at about waist level with enough space to move around the head end of the patient. A table at the room corner is not suitable. Pre-examination counseling regarding the bright light is important. Start with a cooperative phakic patient with well-dilated pupils. Shine the light at low intensity first, separating the lids as shown to locate the pupillary red reflex, and then get the lens into position, gently moving it towards you to obtain an image. This exercise is only to get and maintain an image without attempting mental reinversion of the same. A seated patient is again unsuitable for beginners. The Dubois-Amsler retinal chart has 3 concentric circles. The innermost represents the equator, the middle the ora serrata, and the outer the anterior pars plana, with clock hours marked as meridians. Mark the eye, the patient's name and date, and any other details below. A photosensitive patient to start with will add to the discomfiture of the examiner. Note the chart placed here all alone with color pencils on it, and these rolling down can be a distraction. Indirect ophthalmoscopy, learned without drawing, is like a building on a shaky foundation. The chart should be suitably clipped to a clipboard for support, and a single black pencil with inbuilt eraser and hexagonal in cross section is ideal. The 12 o'clock meridian is placed towards the foot end to offset the inverted image issue. The disc is first drawn as a small vertical oval about 0.5 centimeters in the horizontal meridian, along a line joining the 1 and 5 o'clock meridians for the right eye, and along a line joining the 7 and 11 o'clock meridians for the left eye. A common mistake is to draw a large disc. The vessels of even the posterior pole may then get out of the chart, causing confusion. Starting at the disc and standing on the side of the eye being examined, the upper nasal vein, the lower nasal vein, and then the temporal vessels are charted as seen in the fundus, as in this way the patient is better light adapted. A mental impression of the length and branchings of the vein drawn is to be always had with the disc diameter in mind. It is important to only concentrate on vessel tracing at this stage and not get distracted to draw any other fundus findings seen en route. Although an experienced examiner starts from the periphery first, this method of vessel drawing from the disc is ideal for beginners, enabling faster and easier orientation to the inverted image. As vessel tracings become easy, pathologic findings in the fundus may now be drawn with color pencils kicking in. A useful hint is that any peripheral lesion seen without indentation is approximately at the level of the equator, and proceeding quadrant-wise avoids missing any pathology. Practicing ambidextrity provides a mechanical advantage for certain quadrants as seen here. Scleral indentation helps bring details from equator to the ora serrata into view. For this, the patient looks diametrically opposite and the thimble depressor is placed above or below the tarsus as the case may be, and gently slid into the periorbital space as the patient looks back there. Temporal quadrants are first examined and drawn, and then the nasal quadrants after due counseling of the patient regarding any possible discomfort. As one becomes proficient, even a cursory look at all the 4 quadrants may be enough to draw the whole fundus in one go by storing a mental image. In conclusion, the indirect ophthalmoscope is not a scary mystery headgear, but a unique optical device towards which most young residents must be running rather than away. Thank you for your kind attention.